This late onset in the brain I'm a neurologist. The brain, the peripheral nervous system, and of the muscle. The only disorders that we have good explanation for later onset are the metabolic condition where there is an accumulation of material. And we say that there is more and more accumulation, so the cells die further. Otherwise, there are only hypotheses of why the muscle is maintained. Is it a defective muscle cell that we destroy? Why? Actually, this was the old tradition that we destroy while using the muscle, even for the daily activity. So in the very old days, patients, for instance, with Duchenne and from other disorders, they were sort of told not to move, not to do anything, not to do any exercise, which is probably wrong. In fact, we now know for sure that it is wrong not only in Duchenne, but also in GNE Myopathy. So the muscle is not being damaged by the actual daily activity. There is not, muscle is not also a tissue that sort of, replaces itself like the skin or some other tissues that you would say that this cycle is going, sorry for doing all these strange movements, where is it? And so, simple answer to you, I don't know why it is, but many limb-girdle muscular dystrophies start at the age of 20, dysphagia, which is very common, or even later. Yes?
Is there a phenotype map for the different mutants? Like, are there mutations known, and do you know the phenotype, or how strong the phenotype is going to be for the patients?
Well, Dr. Nishino is going to talk about it, right? Are you going to talk? Yeah, he will present in his talk because I've seen, in my own hands more than 150 patients. Okay, examine them and so on, but the vast majority of them have one mutation. Now, this is the Middle Eastern mutation. Although we have few. However, I will tell you immediately, and this is part of the controversies about the phenotype-genotype connection, is that they represent the patients with this Middle Eastern mutation, some of them are very severe, okay, falling into a wheelchair in their mid-20s, and some of them are very mild, still walking when they were 60 and 60-some. That is not a good enough answer. This may be a hint. The experience of Dr. Nishino from Japan is somewhat different, and he has identified, I don't want to break the news before him, but he's the speaker. I'm sure he will mention a little bit more details about the genotype. Yes?
And with plenty of time, can you tell us a little bit about therapy? Why did the ultrasonics fail? Giving them the silent.
Yes, there is time, but I will kill the meeting because we are talking about therapy at the end of the meeting. So let me just give a very general scheme for this disorder. There may be a metabolic therapy because of a chemical defect, and you will hear a little bit about that. There may be drug therapy, and we should think about it, that would aim not at the primary metabolic defect, but try to arrest maybe secondary pathways, and this is something that I would very much like to talk about later on and to be future. And then we will mention here, Professor Rosenbaum will mention here towards the development of GNE therapy with viral vectors, gene therapy, which is, we are getting there. We are already there. So it is at least 3 avenues besides the exercise therapy, which is good for any muscle disorder. Stem cells is a little bit too far away, but it still will be mentioned. So there are several avenues. Unfortunately, the simple idea of there is a sialic acid deficiency, let's give sialic acid deficiency and people will be cured, has not materialized. It may still be important, but it's not probably the only therapy that will be needed, and that is as much as I would like to say at this stage, and maybe that would be still. But because of this disappointment, and this is just I will mention it, because of the disappointment to all of us, I've been working with this disease since the late 70s. Okay. Because of the disappointment of the supplementation of sialic acid, we want to rethink the whole idea. So we are organizing a workshop, a special workshop from all, I hope all of them will join, worldwide experts in GNE myopathy in the European Neuromuscular Center in Holland in September. This is a closed meeting of about 25 experts in the disease to rethink, rediscuss, do brainstorming. I hope we will start the brainstorming here. I would love to have 10 brainstormings idea even before September so we can discuss. Yes.
Just wanted to ask you that in your very vast experience with a lot of patients, you must have seen siblings of the same family with
Yes.
the same mutations. So how much difference do you see in the onset of disease?
Yes, there is a difference. It is not guaranteed that if one person in the family has a certain type of a disease, a severe type or a mild type, that the other C will have the same severity. In fact, the lady I just showed you is very courageous and so on, started at the age of 19, and so on and so forth. Her brother was part of those 5% who had early quadriceps weakness, and he fell into a wheelchair when he was in his 20s. So there is no guarantee that if you have one C with a certain severity, that the other one, if unfortunately affected, will be the same.
So the question is like when we say brain usually has the highest level of sialic acid, and we say like this whole disease is associated with sialic acid deficiency, and the symptoms are just associated with the muscle. So you show one picture also about this brain. How do you correlate or how do you see the functioning with respect to?
Well, you are touching upon a very problematic issue in the field of GNE myopathy. And I would say that the two opposite leaders of the ideas about GNE myopathy pathophysiology are sitting in this room. Professor Dishido is a strong supporter that this is a sialic acid defect, right? Can I call you like that? We've been arguing this for many years, so we are smiling because we know what we are. I don't think that this is the only explanation. I don't have strong enough proof for that. I hope to be wrong. But if it is a simple metabolic deficiency, then why is it when some patients have only partial lowering of the level of activity, they still have the disease? So in between us lies the truth. It's not it's not completely sialic acid deficiency. I don't think it's completely unrelated to this defect. There is something additional there. Some hints you will hear from Professor Rosenbaum talk about the possibilities, but we don't have a good answer. As for the organ predilection, why there is a sialic acid deficiency, other important tissues are not affected, like brain, like heart, and so on, definitely goes wrong, but that is known in muscle diseases where you have a defective gene that you can identify in blood cells or in the skin, but only the muscles.
Just on behalf of the patients, I was wondering if, a lot of us have questions about where gene therapy is going. Could you just give us an update?
On the therapy?
Yes.
We have a lecture about it. About it. I know you're very anxious. From your point of view, and the patient community, you would like to hear the final discussion about therapy and the rest of the science. I think it's wrong. Now I'm serious. I think it is wrong because part of the problem is that we don't fully understand the science of this disease. And if we will not fully understand the science of this disease, then we may, I hope I'm wrong, we may have another major disappointment like we had this summer with the failure of the metabolic. It's still on cooking and you will hear about it. So I gave you an overall. I'm ready to answer any questioning personal, as I said, even during dinner. Not to worry, patients who would like to write to me, my email address is open to you, but I don't think I should kill the whole meeting by giving
Just last. Yeah, as a patient, I would like to know, since now many people are taking unofficially on their own cialic acid or Manac, some people have also tried taking both. So what would you recommend as of now for us till the time any proven therapy is
this has been the issue all the time. Would I recommend something that was not tried and was not proven? And the patient would say, rightly so, like you. While you scientists are still thinking and doing experiments and waiting for regulations, we patients are progressing, we want to give it a try. I never recommend to do this thing. And I'll give you just one example, although not from the GNE. There is a terrible disease called amyotrophic lateral sclerosis, ALS or motor neuron disease. There was an idea that an antibiotic could overcome the defect, and a trial was running. Then patients, including myself, started taking, by the order of some physicians, this antibiotic by saying, this antibiotic is available, it may affect the mechanism, why not use it? After, I think, the trial was running for 1 year, it turned out that those patients who took this antibiotic that on a cell level was supposed to be improving has not only failed to improve, but those patients taking it became worse. Okay? So you can